Mr. President, thank you for your invitation. I'm very cognizant of the fact that it's the 50th anniversary of our association. I'm very aware of the privilege, and I'm delighted to be here. How do I change the slides? Ah, there we are. Age shall not weary, nor the years condemn. Oncological craniofacial surgery. Thank you for this somewhat difficult brief. Continuing on from David, I'm going to discuss to an extent where we've come from, where we are, and indeed where we go from here is perhaps more difficult than how we got here. And let me see if I can develop this theme. First of all, the field of skull-based surgery, if you can call it a discipline, and I think we can, is relatively recent. It's just about 20 years to go today, as the Beatles said, that we formed the British Skull-Based Society. The gentleman in the back row with the smile will be familiar to us all. The rather diminutive colleague in front, Danny Archer, will also be familiar. And this does give me an opportunity to say thank you, Danny, for opening the door through which most of us followed. And I'm grateful to you. I know that you're here somewhere, but it just gives me an opportunity of thanking you publicly for your commitment, contribution to this discipline and our role in it. 1992, we were preceded only by the American Association of Skull-Based Surgery, whose founder president was Paul Donald. Mike Gleason was instrumental in setting up the European Association in 1993, so relatively recent. I'm going to touch very briefly on anatomy, and I'm very mindful of the audience. Nowhere else in the body have we got so many surgical landmarks to locate ourselves, to orientate ourselves extracranially to intracranial. And I think that the Symposium is the face behind, or that the brain behind the face. But indeed, the thing that is related, and the only thing related, of course, to the anterior cranial fossa is the face. Tumors spreading posterior to the face are clearly going to involve the brain behind the face. Paul Donald in the 80s and 90s introduced the idea or the concept of dividing the skull base into central and lateral components, and he used the intrapetrous carotid as a landmark. Conceptually, and indeed in terms of the way we approach our cases, this has merit because the central skull base, we're dealing with sinonasal disease. Lateral skull base in relation to the anterior fossa, we're dealing with orbital pathology. But rather than use the petrous carotid, which is variable, which is angled, I think the landmarks that I find more useful are in fact the optic nerve at the orbital apex, not so much the intrapetrous carotid, but the intracavernous carotid. These are of value because they're all in the same plane as the medial wall of the orbit, the lateral wall of the nose, the medial pterygoid plate. And these landmarks are sure and certain, and they're not reliant on the varying degree of pneumatization of the paranasal sinuses. If we factor into that the cavernous sinus, these three structures, being in close proximity, will influence whether we decide that we can treat this patient, if you will, with curative intent. The other factor, the corridor actually between central and lateral skull base is relatively narrow. The other factor, other structure to factor into this is, of course, the Gasserian ganglion, but more important, V2 going through rotundum, V3 going through ovale. These are particularly helpful when we're dealing with pathology extending as it will into the middle fossa. They're extremely useful landmarks marking the anterolateral and infralateral aspects of the cavernous sinus, and we can tell extradurally whether we're actually going to be able to get this tumor, depending on what we think is gettable or not. And in terms of organ preservation, in a resection such as the one on the right-hand side, preserving V3 at foramen ovale is going to make a huge difference to that patient's quality of life so that he has a partially sensate face as opposed to an anesthetic face. So the landmarks are there for us to use. Now, as we know, the structures in this area offer very little resistance to the spread of disease, and the peculiar triangular anatomy of the middle fossa, and we are dealing with pathology really at the apex of the middle fossa. Tumors have to spread a relatively short distance before they're involving the structures that I've alluded to, the ICA, the optic nerve, the optic chiasm, the pterygopalatine fossa, etc. Anyway, enough about anatomy. Skull-based pathology, the fascinating thing about pathology of the skull base is that nowhere else in the body have we got such a range of pathology arising from so many different structures that we have at the skull base. Coming back to what David was alluding to, the problem here, if we add the rarity of some of these tumors, how do we have anything but level 4 evidence in trying to decide how we treat these patients best? It is going to rely on institutional memory and individual experience. The majority of these are malignant. If we're just looking at sinonasal malignancy, the majority are going to be represented with SCC and adenocarcinomas with whatever series that you look at. The papers, however, that we see in skull base articles, however, dealing as they will in the majority of cases with sinonasal malignancy, eliminate or do not discuss pathology that we as maxillofacial surgeons are treating on a regular basis, that is orbital tumors and hyperostosing meningiomas, which form a large part of our practice, and indeed an area that we have much to contribute. Some typical examples of pathology, familiar to us all in this area. And we see not infrequently the results of successful earlier treatment. The young chap at the top was the result of successful treatment of bilateral retinoblastomas as an infant. The girl at the bottom, not dissimilar from that. Esthesia neuroblastomas, making significant advances, recurrent tumors. Although we concentrate on malignant pathology, we must not forget that benign pathology such as meningiomas are the source of significant morbidity and indeed mortality in a small percentage of cases. These are diseases that we manage rather than cure. Relatively infrequently do we see aggressive BCCs at the skull base, the hyperostosing meningiomas I've alluded to, and simple pathology like the schwannoma going through V3. So the pathology is fascinating and it's wide-ranging. If we look at the incidence, well, we know that sinonasal malignancy accounts for less than 1% of tumors. For some reason, and I don't know why, the sphenoid and the frontal sinus seem relatively low in terms of site of origin, and I've not worked that out as yet. Now, where have we come from? Well, as Andrew Brown said yesterday at his masterful Norman Rowe lecture, I'm not going to paraphrase Andy, that's a dangerous thing to do, but if I can borrow from him, I think those who think they're doing something for the first time have either not read or actually acknowledged the literature, because it's usually been done before. And indeed, as in the cases that Andrew showed in his lecture yesterday, skull-base surgery was carried on in the 19th century and in the early part of the 20th century, and I'd recommend our trainees to read some of these early articles. Cushing, always worth a read. 1900, he was 31, I hate him, when he reported this. The first person to mobilize, he did a zygomatic osteotomy to access the Gasserian ganglion using those landmarks that I've already mentioned at V2 and V3 and put it back. Talked about temporal hollowing, 1900. This, however, if we're dealing with malignancy, is the original paper, as it were. And this is a hallmark for a number of reasons. One, because they had the courage to do it. Secondly, because they broke down that taboo of opening the cranium to the upper aerodigestive tract. And you can see the life expectancy of patients with malignancy of the sinuses at that time, 5 to 18 months, quite an extraordinary figure. And you can see why Ungren's line became important to us. But the group who I think par excellence, and I've likened them to the Wright brothers, really, because they were so far ahead of the game. Ketchum, Wilkins, Van Buren, and Smith. This was before the era of CT scanning. And a number of us in this audience will be familiar trying to assess any information from polytomography. John Williams, Andrew Brown, Peter Banks, myself will all remember looking at these images. It was like an Ibsen film. It was through a glass darkly. You had no idea what you were looking at, but you nodded sagely and hoped that no one else knew that you actually knew very little. They were looking at these images and look at the craniotomy. They were a small craniotomy. This is almost blind and with an osteotome resecting the central skull base. These were brave surgeons, as Andrew said, brave patients. Interestingly, they excluded involvement of the pterygopalatine fossa. They thought that was inoperable. Anything that involved the dura or transgressed the dura was likewise inoperable. They could only assess by looking in reality. But nonetheless, despite a 4% perioperative mortality rate, 49% 5-year survival rate. That was truly remarkable. And we've got to remember that's where we came from. The group that I think also needs to be acknowledged, treating as they were patients between 66 and 77, was Tertz and his colleague who extended these resections into the pterygopalatine infratemporal fossa, an area at that time that surgeons approached with caution. But nonetheless, 50% disease-free survival at 5 years and no recurrences in the pterygopalatine fossa, again, prior to CT. And again, if we go back to Ketchum's work, this was before the seminal work of Paul Tessier and Patrick Jerome. And that has to be borne in mind also. And I think the group in UK, I think we've really got to acknowledge the work of Tony Cheeseman, who really, I think, put Royal National on the map in terms of skull-based pathology. His technique has altered little, followed on by Valerie Lunn and David Howard, and the technique has altered little since he started it, and these images were taken from the 2012 textbook. But Tony Cheeseman has made significant advances, and I'm happy to acknowledge it. This is not a how we do it talk, but very briefly, I'm just going to discuss the surgery, if you will. I'll touch on endoscopic surgery later because that, to an extent, is the element in the room. I've divided it into approach, the extent of resection and reconstruction. The latter two actually are the most important. How much we remove and how we reconstruct it. How we get there, actually, it doesn't matter because it's basically the same. This is the gold standard. How we do our craniotomy, it doesn't matter. Whether we do it through a mid-face degloving or a Weber-Ferguson or an otomy, actually, let's not lose too much sleep over that. We all have our favorites. The resection clearly is going to involve the anterior cranial fossa in 90% of cases. Perhaps 10 to 12% will involve a composite resection of the middle fossa as well. The subcranial resection, of course, is going to be dependent on the site and nature of the malignancy. Whether we do this en bloc, or as Paul Donald used the lovely phrase, modified en bloc, aka piecemeal, does that matter? Well, let's talk about that later. We do expend a lot of energy, and we don't feel we've done a good job unless we've got a specimen we can deliver almost to the pathologist like an offering in one piece. Does it matter? Well, let's look at that in a moment. The reconstruction, right, the majority of cases, because of the nature of the pathology, are going to be reconstructed with local tissue. Free flaps have made a huge advance in our ability to treat more complex patients. The original surgery by Tertz's group was actually mutilating. And there are many people in this room, East Grinstead, Liverpool, who have made significant contributions, James Brown, David Vaughan, Andrew Brown, to the reconstruction in this area. It has enabled us to reconstruct these patients so that they're not mutilated, and indeed, the ability to provide them with implant-retained prostheses has allowed us to rehabilitate them. Steve Dover and his group, Tim Flood, I know you're here, have made significant contributions and have published on this. Fairly standard, nothing new here. The reconstruction and the resection can involve simply the central skull base, as in this case here. It may be confined to the lateral skull base, as in this girl with the schwannoma, or may involve a more composite resection involving the middle fossa floor. The reconstruction, these couple of slides in this case with anesthesia neuroblastoma, reconstruction simply with local tissues, back almost to the well, certainly to the region of the chiasm. These cases here, this young fellow with a chondroblastic osteosarcoma, the resection, nothing new, but the big change is to rehabilitate these patients. This young fellow now is one of our neurosurgical unit's physiotherapists. He's 7 years post-surgery, and he now counsels our patients. And I think it's quite extraordinary what we've achieved. Reconstruction, in this case, very simple, simply with a temporalis flap. In this case, of course, with the more extensive resection involving the middle fossa, a rectus abdominis flap, TFL, tensor fasciolata for the base of the skull. He died some months later with metastatic disease, and I'll touch upon that at the moment. Whichever, this paper from the MD Anderson group, essentially as maxillofacial surgeons, in my practice, I'm really limited to region 1 and region 2, anterior to the petrous, and do not get involved in petrosectomies unless I'm assisting an ENT surgeon. So I don't think there's anything, this algorithm is one I'm sure that we're all familiar with and using. So that's how we do it. Interestingly, if we look at the experience in the Gray's Inn Road group, David Howard, Valerie Lantoni, Cheeseman's group, interestingly, none of their patients required a free flap, which has to reflect they were dealing with relatively small tumors, and I don't mean that in a pejorative sense, but the tumors were relatively confined. It had to be, otherwise they would have had to use a free flap. When you're moving to larger resections, then the percentage of free flaps is clearly going to increase. And I think our ability to reconstruct safely and to seal the intracranial contents from the upper aerodigestive tract has really transformed our treatment of these more aggressive malignancies. Contraindications. Are there any contraindications to craniofacial resection? Well, the answer is no. There are relative contraindications. Interesting, the ICA involvement. But if we look here, certain histologies, mucosal melanoma, the outcome is so poor that it's not felt to be worth doing an extensive craniofacial resection. Let's just touch on this, because this, I think, is important. Craniofacial resection may be considered as a palliative procedure. Now, that is a subtle change in mindset, is it not? This sentence is creeping into the literature, and indeed we're faced with it. Patients present with tumors deemed unresectable on these criteria, a palliative resection can be considered. Now, this mindset can only, and must perforce can only be considered because we can reconstruct these patients and we can rehabilitate them. What we're saying is that in selected cases, it's okay to bury tumor because we think the quality of life we can offer that patient, even if we don't cure them, may actually improve the months or years they have ahead. And that is a paradigm shift that has not actually, I don't think, really been acknowledged in the literature. Our approach to some of these cases, selected certainly. If we look at the prognostic indicators for outcome, these are important because they're going to give us some idea whether we, hand on heart, can say to our patients, we can treat you with curative intent. Well, there are four things, basically, that influence outcomes significantly. One, negative margins, nature of the tumor, brain involvement, and orbital involvement. T4B, for those not familiar with the classification, is really those most aggressive tumors involving the orbital apex, a short distance to the chiasm, to the cavernous sinus, etc. Let's look. So if we look at surgical margins, if you've got positive surgical margins, your 5-year survival rate is going to drop down to about 25% as opposed to the significantly higher figure. 1 in 4 is a feature that seems to come through this. The histology of the primary tumor, if you have an esthesioneuroblastoma or factory neuroblastoma, our 5-year survival rate is now of the order of 75% compared to 60-odd% 10 years ago. If you've got a malignant melanoma involving the skull base, you're probably better off not doing a craniofacial resection because the chances of you lasting beyond 2 years are remote. And then adenocarcinoma, squamous cell carcinoma, overall 5-year survival rate about 50%. Intracranial extension, likewise, if we come down, if the brain is involved, it's 25%. But the interesting thing is, not so much that it's so low, but actually it's so high. If your brain is involved with a malignancy, you still have a 1 in 4 chance of surviving. That, to me, is fascinating. Fascinating is probably the wrong word, but it's certainly interesting. This paper, I think, is very, very interesting because they took this one stage further. They quantified, or they broke it down into, is this simply transdural? Has it come through the dura but not invaded the brain, or has it invaded the brain? Well, these are the sorts of resections that they're doing, resecting a portion of the brain. Now, the interesting thing here, the fascinating thing is that if you factor in high-grade tumor pathology, positive margins, brain invasion, then your progression-free survival is only 8 months. So we are getting closer to a position where we can really say to our patients, yes, we can do it, but the chances of survival are not good, but it may be worth a palliative resection. That is the paradigm shift in my mind. The question of en-bloc resection, there's so much nonsense talked about this. We know whether you get an en-bloc resection or not, it doesn't really matter, but you don't want to say that in the comment, oh, it came out in one piece, it was a terrific resection, but you're not going to show a picture of it because if it's anything like my resections, that I take them in bits to the pathologist, because we know in most instances, or many instances, because of the nature and the spread of these tumors, you're not going to get them out in one piece. The important thing is not whether they come out in 1 piece or 2 pieces or 10 pieces, but whether you can get clear tumor margins. That's the only important thing in this particular equation. Orbit involvement is a negative prognostic factor, and there's a lot of discussion as to when and when you should not resect an orbit. I think the Gray's Inn Road group, perhaps the most common. There's not time to debate this. We may be able to discuss it later. You cannot tell with CT or MRI accurately whether the periorbital fat is involved. Their proposal is that if on frozen section it's gone through the periorbita, you resect the orbital contents. And on that basis, they preserve 50 orbits. The 5 late exenterations did not influence the outcome of this group. ICA sacrifice, and touch on this briefly because it's a subject that exercises a lot of people, but how frequently do we do it, and indeed should we do it? Well, I think that the MD Anderson group say, look, if it's involved, we're simply not going to do it. This is a bad prognostic factor. If we look at these papers here, the International Collaborative Study, the Gray's Inn Road, and the mono-institutional experience here, 959 patients. In none of those patients was the ICA sacrificed. This is a very good paper, I thought, from Jatin Shah and MD Anderson, looking, and the Cornell University. They don't actually believe that resection is appropriate. It does occur, but they've suggested whether malignant tumors with major vascular involvement can be cured with resection remains controversial. It can be done. It's more common in lateral skull-based pathology. But for anterior craniofacial resections, the incidence of this is actually very low. There have been very nice papers from Sheffield on revascularization, but it's horses for courses. Is it appropriate in this group? The fact that we can do it is not an indication for its performance. If we look at the current outcomes very briefly, we go back to the 60s. We have improved. We've got a 59% 5-year survival rate overall for malignancy. It does drop down to 40% at 10 years. Endoscopic versus open. I don't want to dwell on this, but this position paper, which you can access online, they've got absolute and relative contraindications. We're going through a phase at the moment, and I want to come back to the point that I made at the outset. The relative infrequency of some of these tumors makes it difficult for us to collect sufficient figures to get above level 4 evidence. We have, I think we've got people, endoscopic surgeons, who are very responsible in trying to collect data, but it still does not stop the occasional player who is not a cancer surgeon doing it. But I think we have to compare the results quite closely with the results that we've achieved by open resection. I'm not an advocate for either, but we think we need to be very careful how we proceed, and we need to compare like with like and make sure that one technique is not cherry-picking if we're going to do the best for our patients. There's no doubt that endoscopic surgery has transformed the treatment of such things as chordomas and olfactory neuroblastomas. Benign disease I'll mention in closing, just to make the point that benign disease in this area does not mean benign pathology or benign behavior. There's a significant morbidity and indeed mortality. And this lady, many of you have seen these slides many times. They're sort of I love me slides, but I rarely show the next ones because 10 years, we know we're not curing these patients. The tumors come back. What we're trying to do in these patients, very often with good fields of binocular single vision, is control the disease without actually wrecking their eye. And you know that they're going to come back, and this lady I'm about to operate on again in a few weeks' time. Our mindset as to how we treat these clearly is going to be determined by the pathology, and we can expect, I think we're better able to counsel patients with this type of disease because we've got them for a very long space of time. And finally, where are we? I think that what determines whether we can treat with intent of cure is got to be tumor biology and the quality of life that we can offer, and indeed the patient will accept. But I think one of the things that the paradigm shift that we've not acknowledged is that we are seriously thinking of aggressive surgery because of our advances simply to bury tumor to improve quality of life. That's quite a different mindset. And I think we can do that really because of the advances in our ability to give them prognostic information using those prognostic indicators, and I think we can have a realistic discussion with patients. So the question now, I guess, colleagues, is not so much how we do it, but when we do it. And I think we've got to be honest with ourselves and indeed our patients. Are we treating with curative intent, or is there little chance of doing that? Or are we actually saying to them, look, you're probably going to succumb from this tumor, but we can offer you this. And that's quite a different approach, I think, to malignancy. Mr. President, thank you. I shall stop there.